demand for what we do has never been greater. But within that context, please remember that Diamond is engaged by hospitals and other healthcare providers to be the proactive expert, to provide clarity and solutions that work for that individual hospital and market, given the range of environmental factors we just identified.
I'm so grateful that you've asked me to speak here today, and I'm so grateful that all of you are here to find out better ways to work with one another and to advance the mission of Diamond Healthcare. I believe this is the struggle and the fight of our generation. It continues the great struggles that my family has always been part of for social justice, and those struggles continue as well. Because if you think about it, who are amongst the most marginalized people in our country than people who suffer from mental illness and addiction? John F. Kennedy, in the final act that he signed into law, was the Community Mental Health Act. And in that act, at the signing ceremony, he said, people with mental illness and intellectual disabilities, quote, need no longer be alien to our affections or beyond the help of our communities. And I think that says it all. If you want a policy statement that encapsulates where we ought to go in this country, that is it. We shouldn't have stigma, and we should treat people wherever possible in their communities. It's as simple as that. And the Community Mental Health Act of 1963, you could pass it today, and it could do more to tackle the incidence of mental illness and addiction than perhaps any piece of legislation you'd want. The problem is we've never funded mental health and addiction, and that's why we're in the state of crisis that we're in today. So because of the Civil Rights Act, we said, I don't care if you have prejudice. You just can't practice the prejudice. And what the parity law says is, hey, you guys go figure out your denial and your stigma, but while you're figuring that all out and sponsoring all your, damn anti-stigma campaigns, just pay for this damn thing the same way as you would any other illness, because there is a new Medical Civil Rights Act. And it says you cannot treat these illnesses in a separate and unequal way.
I want to talk a little bit about the opioid crisis. You had raised that, and Patrick Kennedy was here yesterday and had a few choice words about that. Very passionate, and I know you know of him and have spoken with him on a number of occasions. And we spoke, so I'm not asking a loaded question here. There's a lot of blame to go around, all parties, pharmaceutical companies, pharmacists, prescribing docs. We can point out who the bad actors are, and I don't find that to be a particularly productive way to go. More, let's find out how to solve this problem. Where do we start?
And I think you're right. I agree. And certainly any person, healthcare professional, entity who is acted out of the bounds of their ethical and legal responsibility need to be addressed and need to suffer the consequences appropriately. But the bigger issue is, I think, where do we go from here?
Yeah.
And at the AMA, at this point, we are focusing on treatment and the need for access to treatment. And we are very focused on, of course, the evidence-based treatment for opioid use disorder, and that is medication-assisted treatment. And we know that in this country, 2 out of 10 overall folks who want medication-assisted treatment have access to it. And then they have access to it perhaps with barriers. And so we have been working very hard to remove the prior authorization barriers to medication-assisted treatment. We've Pennsylvania, their governor, their insurance commissioner have a voluntary agreement with the 7 largest payers in Pennsylvania to eliminate prior auth for medication-assisted treatment and to make sure that at least one of the medications is on the lowest cost sharing tier So we are working hard. We are doing work in Pennsylvania. We did work in Colorado, North Carolina. And the reason we did that is we wanted to choose states, and we want those states to be the roadmap for all states. I have a slide when I do my opioid presentation. Pennsylvania was the first state, and it said, if Pennsylvania can do it, why can't you? So we are very, again, passionate about the treatment issue. We were supporters of the HR, I believe it was 5, that the President signed into law. Now that was just the first step, as you know. You have to appropriate money. So if it's $10 billion in a law and no one ever appropriates money, then it's no money. So we need the follow-up, and we need to all continue to advocate to make sure that money, which is not enough, but. And the other issue, and Jim and I were talking about this, and this is just from my view as a psychiatrist and just over the years, and just my bent towards systems thinking, and probably my experience in public health is, in this country, we sort of careen from crisis to crisis. And we'll fix this, and we'll focus on this, and money, sometimes a lot of money appropriately. And then we move on to the next crisis. And I think I would want us to look back and think about developing an infrastructure. What would a good, solid infrastructure look like? Even if you look at the Ebola crisis. Rather than going through the rigmarole of how much money do we need to spend on Ebola, and why don't we look back and develop an infrastructure for the next big infection, because we are a global society. There's going to be another Ebola. There's going to be another opioid. And so it would make more sense to have an infrastructure, and we all know in this room that we have not had an infrastructure for mental illnesses and substance use disorders. So we need to work, while we absolutely have to be really aggressive right now with opioids, absolutely, but also we need to look at the bigger picture and make sure there is infrastructure in place that we can manage. So it's about the dollars and making sure we get the dollars in place. So I'm very proud in that we have policy on myriad issues that folks can use either at the congressional level or at the state level, or in your own health systems. Mm-hmm. Believe me, we have a lot of policy around health systems. And we hope that people use those policies to enhance the ability of all of us to care for our patients.
And so our goal is to take this disciplined conceptual model that Diamond has provided us and backed up with statistics and financial performance, and to implement this with a plan, not just sort of a well-intentioned effort, but with a systematic approach. And early on in this, I went to the Department of Health, which is the source of all sustaining funding in New York State, and presented this, and was received with inexplicable and never before seen enthusiasm, I must say. It was quite remarkable on their part that when we just said, this is the plan. Now, that's our plan. I want to conclude by talking about the facts of life, about this is the plan in an organization that is a healthcare organization trying to survive. And that our margins are eroding, as is the case with most. We know Medicare is planning on paying less. That's 50% of our payment. Medicaid is moving to managed care. Well, it is in managed care in New York State, and it's going to get worse. And Rich alluded to that study about the suicides, children's suicides in managed care. I was not going to bring that up, but he did. So it's a concern, right? That's where we're going there. So here's an approach that doesn't directly address all the things we're trying to do, but it tells you the way we have to tilt, I would say, as an organization. And I think we have to recognize the fact that we're in an internet economy now, that the structural relationships of buildings and people traipsing to a building for service are eroding. We have to consider that all our resources, our telemedicine, the people have cell phones, apps. West Virginia is so far ahead on this, large part to him, due to his efforts, but doing AA meetings by teleconference. These kind of things where we can mobilize our resources more effectively. And that's where we're putting a lot of our activity. We're also assuming that a lot of the ambulatory care market, the CVSs and the Walmarts are going to start creeping in to take that. They are not going to be seeking behavioral health services. I predict, that's not where Walmart's going to make its move. And in the meantime, we have to focus on our costs, continue to optimize our EPIC investment because that's the way we tie it together. That's where our analytics are. You had your cybersecurity session. It's sort of everyone's unending obligation now. And we're looking for the ways that artificial intelligence can help some of our back-end work, but just very cognizant of the fact that it doesn't appear to be, it's going to be something that's going to help us in the front here. So our goal as a health system is to bridge this gap so that we can continue to provide access, control these costs, have Diamond and other experts be part of our fabric, not just a consulting engagement. So recognizing the fact that our expertise is our expertise, it does not traverse all fields.
Dale Carnegie said that people come to events like this, and I'm going to generalize a bit, but he said he came to events like this for 3 reasons: to be inspired, to be motivated, and to learn something. In that order. To be inspired, to be motivated, and to learn something. So if there's any way I could inspire you beyond what I understand Mr. Kennedy did, well, boy, that's pretty high cotton to be walking in, but I could certainly hope so. Motivate you, perhaps. Maybe I'll motivate you to think about or do something differently. But I'm a professor, I'm a teacher by nature. So if I could help you learn something, that would be my primary goal. So I'll come back to Mr. Carnegie a bit more in a few minutes. At the end of the day, when we're out there mixing it up in the marketplace, there are 3 elements, here we go again, 3 elements I would argue that are always at play. Go back to that brand positioning idea. Number 1, how we are perceived by others. How we are received by others. And those 2 things often based on the value we are bringing to others. Perception, reception, value. I'm a sales guy. I'm a marketing guy. My most lofty accomplishment is being a professor, but I'm a sales guy. I'm off the street. I sold for years and years and years. And it took me a long time to learn was nobody buys anything unless they sense value in what it is you are trying to promote, encourage, lead towards, etc. Only to the extent that there is value in it for them will they act. Seems somewhat commonsensical, does it not? But for a sales guy who was measured on numbers and driven to produce and bring business in the door, I got so caught up in my own agenda that I often overlooked the very basic tenet or fundamental that until I'm positioning something and bringing something of value to that other party as they perceive value, do I even have any skin in the game? How we're perceived, how we're received, and the value that we can bring to that audience.